individual anatomical variability that could have practical clinical implications. Also, the accuracy that we found of this ultrasound-guided injection.
Thank you. Are there any questions from the audience? I have actually one question. Maybe I missed it, but I hope I pronounced your name correctly. And he's presenting on the use of cable ties for the management of incisional hernia repair and acute celiotomy dehiscence.
Good morning. First of all, we would like to thank ECVS for the opportunity of being here. I am excited to present you the use of polyamide cable ties for the management of abdominal hernias and acute abdominal dehiscence. So incisional infections is a common complication after equine laparotomy, and the most prevalent complication that precedes acute abdominal dehiscence. And although uncommon, acute abdominal dehiscence is or could be fatal if it does happen. So if the horse is at risk of evisceration, an emergency surgery should be performed, and the survival rate after that procedure is close to 56%. A most used method to repair this problem or to overcome these problems consists of primary closure of the linea or secondary closure of the linea using stainless steel wire with mattress suture pattern using a rubber tubing to pass the wires, or a combination of both. So the most usual complications after this technique with the stainless steel wires are the wire cutting through the skin and muscle, and there are also difficulties to remove the wire once it is buried within the granulating tissue. Also, there is a high prevalence of hernia formation. As with acute abdominal dehiscence, ventral midline incisional hernias are also an uncommon complication after laparotomy, and they are a result of partial dehiscence. The rates are reported to be within the 8 and 16%. The presence of infection also is the most important risk factor for ignition. And large effects may require prosthetic reconstruction, and most of the described techniques use mesh hernioplasty. All of the techniques reported need at least between 8 to 10 weeks in order to overcome the infection to start a procedure. Lateral abdominal hernias are also an uncommon complication. In falls, they can be congenital or acquired, and in adults, they are only acquired and mainly traumatic. Depending on the force associated to that trauma, there could be also internal organ damage associated. And when these hernias are large, like the one shown in the picture, they might require prosthetic reconstruction also. And there is also complications associated to the use of this synthetic non-absorbable mesh, and those complication range are within 20 or 60% according to the reports on the literature. Persistent incisional drainage, seroma, mesh infection, hernia recurrence, intra-abdominal adhesions, and mesh or abdominal wall failure, recurrent colic and peritonitis are within those complications, and mortality rates are as high as 50%. So the objective of this study is to describe a novel technique for the surgical management of large-size abdominal hernias and acute abdominal dehiscence in horses. A retrospective study of 50 horses treated with sterile polyamide cable ties in different referral cases by 2 surgeons, Dr. Jose Berocay did 46 of them, and I did 4 of them, were included. 43 cases were treated with large incisional hernias with healthy hernial sac that those hernias develop after first colic surgery. Other 5 cases were treated for acute total dehiscence after celiotomy. 1 case, the surgical technique was used to repair the linea after a resection of an extensive abdominal lipoma, the picture on the upper right corner. and one that developed a mesh infection after the repair of a big lateral abdominal hernia. So some general aspects of the surgical technique. Primary closure of the linea was performed only on the cases that did not have an infection. No subcutaneous sutures were used in most of the cases, and the skin was closed only in non-infected cases also. In all of them, 5 mm wide, 40 cm long sterile nylon cable ties were placed in a Lambert suture pattern as shown in the picture. 4 perpendicular incisions were made, and a curved jelly forceps was used to thread the cable tie through the incisions. So after that, 3 sterile cotton wool gauze or sterile towels were used. 1 of them under the cable tie in direct contact with the wound, and 2 of them within the cable tie loop. The gauze rolls provide wound dressing, tension relief, and protection from direct wound cable tie contact. The zip ties were tightened whenever they cut through the tissue and got loose, and they were usually retired between 14 and 20 days. The gas changes were made in most of the cases between day 7 and 10 after the surgery whenever the cable ties got loose, since they cut through tissue. However, in other cases, like the ones that had surgical site infection, there was a necessity of changing the dressing or the bandages earlier, like the one shown in the picture at the right. So those cases were mainly the ones that had infection and the skin was left open. In those cases, there was some difficulties to change the bandages. However, that problem was overcome in one of the cases with the use of a releasable cable tie. So specifically, the surgery was used in 43 cases with large, healthy abdominal sacs. And those repairs were performed at least 4 weeks after the first surgery when healthy tissue was present. In those cases, a primary closure of the abdominal wall with metric size 6 polygliding 910 was used in a continuous pattern, and the skin was closed also in a continuous pattern. No subcutaneous sutures were used, and then the nylon cable ties were used as a reinforcement of that primary suture. In other 5 cases, the technique was performed during the second emergency laparotomy. In 3 of those cases that had surgical site infection and the eyes, and another one that had a tearing of the abdominal wall and eviscerated 3 days after colic surgery, and in 1 mare that aborted 2 days after colic surgery. Primary closure of the abdominal wall was performed only in the non-infected cases, and then the nylon cable ties were used as a reinforcement of that. The 2 other cases that had no infection did have, the 3 cases that had infection, no primary closure was attempted, and the zip tie technique was used as a secondary closure method. No subcutaneous or skin was used in all these 5 cases. In here we can see a picture of the mare that tear the linea after abortion. And here's the same mare after the primary closure. You can see the edematous tissue and the abnormal appearance of the tissue. This is a case that had a large infiltrative abdominal lipoma. So that horse went to surgery, and then the tumor was removed. As you can see, there is the large external tumor, then the infiltration of it in the abdominal wall, and the large internal mass. It weighed 25 kilograms. So after the resection, a huge incision was left, and there was a lot of tension during the attempt of the primary closure. So the technique of the cable ties was used as a reinforcement of that primary closure. In one case, the technique was used after the repair of a large lateral traumatic hernia. So the mesh was placed and got infected. The mesh was removed, and then the nylon cable ties were used, this time passing through skin and external abdominal oblique muscle. So 90% of the horses were discharged and survived a follow-up period of 12 months, and 10% of the horses died. Those 5 horses that accounted for the 5% that died, 3 of them were the ones that had the surgical site infection, and they were euthanized after the second surgery because they developed peritonitis. 1 horse died of acute renal failure and never recovered from anesthesia, and the other horse died 2 weeks after second surgery because of an IV selenium injection. So the 3 horses that developed peritonitis that had a surgical site infection we consider that the complication was not related to the surgical technique, hence they were not included for the calculation of the complication rate. Neither was the one that died from a IV selenium injection and the one that died of acute renal failure. So of the 50 horses included in the study, the complication rate was calculated using 45 horses. 6.7% of the horses did develop complication. And despite the fact that abdominal closure failure could happen, re-herniation, and infection, that 6.5% is just 3 horses that got infection of the linea. And they were treated with drainage, lavage, and systemic antibiotics, and then were discharged home, and no other complications or re-herniation was reported after a 12-month period follow-up. This is some clinical evolution of one of the cases. It was a warm blood mare that weighed 582 kilograms that eviscerated 3 days after colic surgery. This is the aspect after the bandage change 4 days after the surgery. And here is a picture 2 weeks after first surgery. Now you can see how the cable ties have got through skin and tissue. And there is healthy granulating tissue in the midline laparotomy, and the primary suture is already loose. This is the same mare already performing 2 years after, and here is an ultrasonography follow-up of the aspect of the abdomen. That's the aesthetic appearance of the wound or the scar after the hair clipping. So, as a conclusion, this technique had no serious complications, and the rates reported or that we found are lower than other hernia repair methods reported in literature. When this technique was used for the treatment of acute abdominal dehiscence, it apparently cuts less through skin and tissue than wire does because of the 4 millimeter wide of the cable tie, and it does not get buried within the tissue. So for all these reasons, we believe that this technique represents a valid alternative for the treatment of large abdominal hernias and acute abdominal dehiscence. So I would like to thank Dr. Jose Berocay, that is here within the audience. He was the one that developed this technique and used it for the first time in 2003. And since then, he has been improving it and teaching it to other surgeons like he did with me. So thank you, Dr. Berocay. I would like to acknowledge that our funding sources are Escuela de Medicina Veterinaria, Universidad Mayor, TRM Chile, and Drug Pharma Laboratory. I will be happy to answer some questions if there are. Thank you.
Thank you. Are there any questions? Yes, go ahead. We need a microphone in front here.
Thank you very much for a nice presentation. So I was curious if you could provide a little bit more details about bandage change. So you said you had some early bandage changes.
Yes.
How did you dare to loosen the cable ties and change the bandage when that was the only one, as far as I understood, holding the intestines inside?
Pardon, I didn't understand exactly.
So as far as I understand, in your cases, you don't do other suturing than the cable ties if you have an infection. Is that correctly understood? So when you have to change the bandage, how do you loosen them and without having evisceration?
Okay. So as I said, most of the cases that we presented were 43 cases that had no infection, and the technique was used to repair the large hernia. In those cases, after surgery, there was usually no necessity of changing the bandage before the 7 to 10 days, and by then the cable ties were already loose, so it was not difficult. However, in the other cases that had infection, there was a necessity of changing the day after surgery. Since the skin was left open, there was a lot of secretion and blood, and in those cases, it was difficult, but with a surgical instrument, you would grab the gauze and just like untangle it from one to the other. It was difficult, it required sedation. However, the problem was overcome when we use a releasable cable tie. So then you would lose the cable tie, untangle it, tie it again, and then keep going with the others.
Okay, we have
Do we have time for
another
one more?
question. Yeah.
Just a little questions about the details. So it looked like you were taking pretty wide bites. Do you have any guidelines on how far you were on the bites and what distance was between the cable ties?
Yes, sorry, I forgot that. I was supposed to say those specifics. So the stab incisions were made 2.5 centimeters and abaxial to the midline incision, and the second one 5 centimeters abaxial to the first one. And then the distance between cable ties usually went from 5 to 8 centimeters.
Excellent. And one more question. How long did you leave the cable ties in? So when did you decide to remove those?
We usually, well, I say we, but I did just 4 of the cases. Dr. Berrokai did 46 of them. He usually removed them between 2 to 3 weeks.
All right, great. I think we have to move on.
Thank you.
Again. We're going to move